another episode of the Girlies podcast. This is your only host right now, Eric, and it's been a week, you guys. It's been one of those weeks where the girlies have to try to navigate around posting an episode for you guys to listen to this week, and we came up with something new. Um, so on this episode today, we're going to be bringing out something from out of the vault of one of our favorite podcasts here on the Girlies, the I Don't Know podcast. Back in around, I think, the start of the pandemic, around early 2020, Girly Lily and Girly Vero did an interview with a licensed medical professional, and we're going to be bringing that out of the vault for you guys to listen to. And just to track back about how our week has been, Alien Aquí spent 13 hours in the emergency room because they were not feeling good. And Alien Aquí is shuffling being our full-time editor, and also is handling a full-time job and shuffling a full-time school, more than 12 units. And Alien Aquí also went on their long-awaited trip to Peru. I hope you're having fun, girly. We missed you here. We can't wait to hear all about your trip. But yeah, so we're gonna be trying something different here. I hope you guys enjoy listening to this episode. It's gonna be a great one. And I'll check in with y'all in our smoke break.
Okay, well, you know what? Before he gets here, can we do a little bit of our experience with psychiatrists?
Sure.
Okay, take it away, sister. What's your experience with psychiatry and mental health and all of that jazz?
So for me personally, I do have both a therapist and a psychiatrist. My psychiatrist is really, really new. I just jumped on board with him maybe last month. And so we're still getting to know each other, but I feel like the majority of the work that is done with me is with my therapist. My psychiatrist is kind of like a check-in, hey dude, what's up?
Okay.
Once every few months, I think. Just to kind of check in with me and see how I'm doing with some personal things. But yeah, my psychiatrist is new and I only see him once in a while. My therapist gets all the tea with me.
Yeah. Okay. Is this the first psychiatrist you've ever had, or have you gone through a few?
No, this is my second psychiatrist. My first one was on and off, and I had her when I was fairly young. I think I was 18, so
Okay.
I didn't really give it a good shot. And so I just felt like if I was really going to buckle down and do work on my mental health, then I needed a new psychiatrist to start fresh. So that's what I did.
Well, I'm glad you mentioned that because I think you and I have had this conversation, and we're going to touch on it in this episode about not being fully honest and transparent with your psychiatrist.
Yeah.
And how that's only hurting ourselves. But I don't know. It's just why do you need to know my business?
That's my business.
Yeah. Okay. So this is I don't want to sound ageist here, and I'm tiptoeing around my words here, but this guy is pretty young. He just graduated, and he kind of gets it more than I feel my older psychiatrists did. The generational thing was something that would always get in the way. I don't feel like they would really understand where I was coming from, and kind of just made me feel not comfy, I guess.
Yeah, because you feel like they can't really relate or maybe not understand fully what you're going through or what you're even talking about. If you want to throw in a millennial term in there, they're gonna be like, huh?
Yeah.
It's I don't know.
I tell my psychiatrist, I've been having a few emotion days. and they know what I'm talking about.
Yeah.
Yeah.
What do you mean? Let's break that down.
Uh-huh. Ew, number one thing that you hate about psychiatrists before he gets here. Let's talk some shit.
That I have to, one thing that I don't like is that because we don't see them that often, as opposed to my therapist, you have to give them the rundown about everything that's happened since your last conversation. And that chunk is just, it's way too big and everything's so broad. It's like, bro, I've had about 23 breakdowns since we've last talked. I don't know which one to talk to you about.
Chicks, you're one. I hate you. Yeah, no, I completely understand. And you go through Kaiser, right? So when I had Kaiser, I recall how hard it was to get into seeing a psychiatrist. How often do you see your therapist, if you don't mind sharing?
My therapist, I see her every 2 weeks.
Okay,
or
that's good.
every 3 weeks. Yeah, if she's like really booked and busy.
Yeah.
So way more often than my psychiatrist.
Okay. And I think we'll probably get into it a little more because we're going to touch on medication as a general topic. But what's your experience with meds? You dabble in the drugs?
I do dabble. Very recently, actually, I just started. So it was a process. It was a long journey that I had to do my research on and, decide if that's really what I wanted to do or not. But yeah, I'm thankful that I have emotional support from both my psychiatrist and my therapist. And, it got me the medication that I need for my personal journey. So yeah.
Good.
I do dabble.
And how long has that been? It's not been very long, right?
No, fresh. So everything's good so far. Hopefully.
Good.
Yeah. Hopefully it stays that way because I know it's not everybody's case.
Yeah. So, I mean, obviously I share all my business on this podcast, so people kind of already know my rundown. But yeah, I've been on antidepressants. I started taking them when I was like 19, and then I stopped taking them when I was 21. I got back on them when I was 22, got off of them 23. Then took like a whole year off, and I was losing my fucking mind. Like, I don't think I realized how much I need it until I was off of it for a long period of time.
Yeah.
I was always on and off. And then I was like free ball in it. And no, that shit's not for me. Whether it be my trauma or whatever the fuck keeps me depressed, like a chemical imbalance, it's going on in there because without this little boost of serotonin that these meds give me, I'm like, I can turn into a wreck hella fast. So shout out to antidepressants,
2 minutes early.
Hi, Dr. Balela Throne.
Hey, can you hear me okay?
Yeah, okay, professional setup.
Nice. Thanks.
This is Lily. She's going to be co-hosting with me today.
Hi.
Nice to meet you.
Nice to meet you.
We already introduced you, and we already talked a little bit of crap about psychiatrists behind your back.
Before you got here.
Yeah.
Oh, okay. Glorified drug dealers.
Yes.
Yeah.
So did you receive our list of things? Everything all good in the hood?
Yes. I mean, there are probably two that I will not give a direct answer to, but I'm happy to explain why as part of the interview.
Okay. So we'll ask them anyway.
Yeah, that's fine.
All right. So we already introduced you again, but this is Dr. Brian Bello. Hi, Dr. Brian Bello. How are you?
Doing well. How are you?
I'm good. Thank you. Okay. Let's hop right into the interview today, sisters and brother. I want you, Dr. Brian Bello, to give us the mental health for dummies breakdown of what's the difference between a psychiatrist, psychologist, and this one is a little more obvious, but therapist, if you may.
Sure. So, I mean, the main one is basically the background of your training. So for a psychiatrist, we are medical doctors. So you go, you do 4 years of undergrad, 4 years of medical school, and then from there, you are technically a doctor. But in the US, most people go on to do like a residency. So, that could be pediatric surgery, whatever. So, from obviously in my case, psychiatry. So to become like just a general psychiatrist who treats adults or any ages really, it's a 4-year residency. But for me, because I wanted to work primarily with kids, and adolescents and stuff. So I did a 2-year child psychiatry fellowship on top of that. And the nice part is like with child psych, you can actually shave off the last year of the general psych. So you end up doing it in the general psych in 3 years plus the 2 years, 5 total.
Okay.
Yeah. So for the other two, so therapist is actually just kind of a general term. There's actually a lot of different ways you can go to become a therapist. I think the most common ways really are usually like a master's in social work, a master's in marriage family therapy, or a master's in psychology, or a PhD or PsyD in clinical psychology. Yeah, so that would be so a psychologist, I guess, technically would be somebody who has a master's or PhD or PsyD in clinical psychology, and a lot of them do therapy. But there's others that are like primarily just doing like neuropsych testing. So like evaluating for, I don't know, different like autism and or personality disorders or whatever.
Okay. So those guys don't give drugs.
For the most part. So this is where
Okay.
it's like starting to get a little wishy-washy, and where like a lot of psychiatrists are actually nationally pushing back. So there are, big drama. I'm on a couple like Facebook groups with a bunch of psychiatrists.
You're old.
I know, I'm old. Dating myself. I was actually a freshman the year that Facebook hit. Like I think I assume I'm the same age as Mark Zuckerberg or whatever. So like,
college freshman.
Yeah, so I was a college freshman. So like when it first came out, sidetrack, there was only like 20 universities across the country, and you had to. So I went to University of Florida for undergrad. So like you had to enter a .ufl.edu or whatever email address in order to sign up for it.
Vintage.
Did you sign up for it?
Yeah. It was like everyone on my dorm was like talking about, because back then it was the Facebook, right?
Yeah.
So it was like the Facebook, you have to sign up, and there was like no timeline, there was nothing. It was just people's profiles.
I think I saw you in the movie.
It's probably actually my med school roommate actually knew Mark Zuckerberg. I think he went to he went to Duke, I think. I don't know. I forget, but he went to he was like at school with Mark Zuckerberg and had some pleasant things to say about it.
Imagine going to school with Mark Zuckerberg.
No,
that's kind of a serve.
Not it.
Kind of a serve.
Yeah.
No. Okay, but why is there drama? What's the beef?
Oh, yeah, sorry. So I think there's a couple states that have approved clinical psychologists, and I think you have to either have a PhD or PsyD, I think, to be able to do it. But that alone they can't prescribe. They have to do like a 2-year like psychopharmacology fellowship or something like that to be able to do it. They have to do in a certain number of hours, like embedded in like hospital and clinic settings, and they're limited to what they can prescribe. I think it's like basically just like antidepressants and a couple other like, lighter psych meds. But yeah, a lot of psychiatrists, again, in these Facebook groups, before we went on our tangent, that they like talk a lot of crap, and they're like strongly opposed to them being psychologists being able to prescribe.
We could be the only drug pushers here.
Yeah, they're very territorial. I mean, it's the same thing with like they're like really a lot of them are like really anti-nurse practitioner and physician assistants being able to prescribe on their own. It's all kinds of drama.
The medical field drama.
Very cliquey.
Yeah.
Okay, you mentioned that you went to the University of Florida. Is that
yeah
right?
Yeah,
okay.
for undergrad. Yeah.
Okay, so what was your 1,000-year of school experience then to become a doctor?
So it was
Honestly,
it was 4 years of undergrad, where I majored in psychology, minored in Spanish, and you have to do pre-med classes on top of your major. So did all my gen eds, my psychology classes, and then you have to do like, a year of biology, a year of chemistry, biochem, organic chemistry, physics, whatever. So you do that, got my undergrad degree, got into med school. It's 4 years of med school. I went to Ohio State for that. And then when you graduate, then you go to your residency. So I did my general psychiatry residency at LA County USC, and then stayed on for the extra 2 years for my child psych fellowship still at LAC USC.
Wow.
Okay.
Ew.
Yeah. 13 years post high school.
So when you were a freshman in your undergrad, did you already go in there thinking or knowing that you were going to be a psychiatrist?
Yeah, I actually I wanted to be a child psychiatrist specifically since like 11th grade.
Oh, wow.
Yeah, which is very rare that people go into medical school wanting to go into psychiatry. Most like surgery, pediatrician, like that kind of stuff, much more common, but pretty rare for people to want to go into psychiatry. Yeah, so my background with that is a little bit weird. So I went to my high school that I went to was actually like a magnet program for engineering. So originally I wanted to do that, but then I took like a psychology 101 elective in like 10th or 11th grade. And at the same time, I used to fall asleep listening to Loveline, which again,
With
probably
Dr. Drew?
Yes. Who's not a psychiatrist, by the way. He's an internal medicine doctor.
Yeah.
But addiction medicine specialist or whatever. But yeah, I used to fall asleep listening to that and just found it like that in combination with taking that psychology elective, I just found like really fascinating, and specifically the whole like trauma and abuse cycle. Just found really fascinating. It was like, I want to do that because I'm like, if these kids that are being traumatized, grow up to be abusers themselves, and a lot of times like the family is involved with the trauma, like, parents are supposed to be your natural advocates, and if they're part of the problem, like who's going to help these kids, right? So yeah, I just decided from there that like I wanted to go into this field and try to help people who are going through these things.
Okay, so he kind of just answered your second question of why he chose this profession, but we have to thank Dr. Drew for having Dr. Brian Bello with us today. Bello. Bello. I always say Bello because I pronounce it in Spanish.
Es italiano.
I know.
Mi madre es boricua, pero mi padre es italiano.
Okay.
She's Latina.
So also a funny side story. I actually got to meet Dr. Drew a couple of years ago.
Oh, wow.
And told him, I got to tell him my backstory, and he was like so honored. He was at Politicon over in like Pasadena a couple of years ago, and he was on like some panel with like Chris Christie or something. And I talked to him afterwards and was like, so I'm a psychiatrist and you're my hero, even though you're not a psychiatrist.
It came around full circle.
Yeah.
Got to meet your hero.
Yeah.
Okay, Liliana, you have another question coming up. This is my favorite question of all time. So I hope this isn't the one that you can't answer. But
Let's see.
Okay, second question. Did you feel the need to battle / overcome childhood trauma, if any, before becoming a psychiatrist?
No, not necessarily. I don't have any trauma in the like that would meet like DSM criteria for PTSD kind of trauma. I mean, I went through a lot of like bullying when I was younger because I've always been a big dork. So like, yeah. So I was picked on. But I would put it this way. So, part of our psychiatry training, in addition to like all of the medicine stuff that we learn, we're also trained to do cognitive behavioral therapy and psychodynamic, or like, Freudian, Jungian kind of therapy. And they very, very, very strongly encourage us to go and do our own therapy while we're in training, while we're learning how to do it ourselves. Because in psychodynamic therapy, it's really important that you know yourself and what your triggers are and how you how you kind of relate to certain types of other people. So that you can be as objective as possible. Because in psychodynamic therapy, you're supposed to kind of be a blank slate and let the patient kind of project onto you all their crap, you know, and then help them work through it. And obviously, if you're like unconsciously being triggered by them, you might start to do things that are kind of like spiteful and not very therapeutic. So I did that. I was in therapy for like a year and a half. While I was in residency, and then did another bout of about a year and finished up, I think, about 6 months ago.
Oh, wow.
Or so ago. Okay. Yeah, just more recently, just, you know, transition or life change stuff, you know, getting older.
Yeah, getting old. No,
old.
Still on Facebook groups.
Still on Facebook groups with all the other old psychiatrists.
But that like takes us right into the next question of how you were mentioning how they'd like have to project to you all their issues. When you go home, aren't you like just sitting there thinking about shit? Like, damn, this girl went through this. Damn, this guy went through that. Like, how do you feel? How do you handle that?
It varies day by day, but definitely, I mean, that's something that we spend a lot of time in kind of processing during residency, because, you know, we get, especially at LA County USC, like, you know, we had a lot of patients that are from some not so nice parts of LA. And so, like, you know, we see a shit ton of childhood trauma there. So, you know, we kind of learn how to, like, you know, decompress and not take those things home with us, and kind of think about, like, you know, we're doing the best that we can. We can't take on everything. We're not superheroes. We, you know, we can't go and like pull these kids out of their homes and stuff. We kind of have to work within the system. You know, and so I think when you get that supervision and you kind of get, you know, people kind of say this, like, I don't know, just to kind of like comfort you. I think it gets to a point where you're able to kind of like disconnect and separate yourself and not take it at home as much. And, you know, I have a couple of roommates, and so, like, you know, obviously I don't tell them any sort of like specific details of things that would, like, you know, for HIPAA, HIPAA reasons, but, like, you know, kind of gist of stuff. And yeah, and that's helpful to just kind of like decompress and have some people that you know, one of which also works in, and like one of my roommates also works in the field, so can appreciate what we're going, you know, what I go through on a day-to-day basis.
That's good. Cracking a cold one with the bros, talking about kids' trauma.
Yeah.
Fun.
Oh, a spicy question. Dating life as a psychiatrist, how is that like when you're coming across new people, meeting new people? You're obviously now your lives are kind of being, you know, intertwined somehow. How is that like?
So this is one of those questions. One of the two questions. So there's two questions that I will not directly answer. Well, so and this goes back to what I was saying before about being kind of a blank slate. So obviously, you know, with this being, you know, it's ultimately gonna be public. So I don't in any sort of public spheres disclose what my sexual orientation is or my relationship status. Because, you know, for example, if, I mean, you know, obviously I'm a cis male, so like I can't disclose, you know, I can't hide that part. But as far as everything else, you know, I have a lot of LGBTQ patients, for example, and a lot of heterosexual bigoted patients. So you know, whether, you know, it may affect people one way or the other depending on, you know, what they,
there she is.
You know, what they think or know about me.
Yeah.
So I just don't. And then, I have a couple patients that I do therapy with, that it's very common in psychodynamic therapy for your patients to like develop amorous feelings towards you. And so like them knowing what my relationship status is may like affect those things, you know.
Yeah.
And it changes the conversation, and it makes it so that they, if they know about my background, then they can start to assume other things, and it may affect whether or not they believe I can actually relate to their experience, etc.
Got it.
So,
Any
Okay.
patients hit on you?
I've had patients imply things. Never anybody
Wow.
like try to solicit anything, but I've had patients or patients' parents like say things about me being attractive or whatever, and I just
The parents.
Uh-huh.
yeah.
Okay, well, I don't know if this is another one that you can't answer because it's kind of personal, but if some loved one, a friend or family member in your life, like you start to notice they're a little sus, can you be like, hey, bro, I think you might be depressed? Or is that not something you do?
No, that is something
Oh,
that I can answer. Yes. If I think somebody is one of my loved ones or friends or whatever in my life are depressed, or I'm like genuinely worried about them,
Mhm.
yeah. I've had I've had other experiences where like, I have some friends that like, don't have insurance or whatever, or
Mm.
it's like kind of burdensome for them to like go to urgent care if they get like a UTI or something. So they'll just be like, yeah, like, can I get some Keflex or
Yeah.
or something, or like a Z-Pack or something, and yes, I will prescribe. I'll call in a prescription for their antibiotic or whatever. Um, I've also had an experience where like one of my colleagues, her sister was like, the first time she was in town visiting or whatever, and we were all out grabbing drinks or whatever, and it was like kind of clear that there was something going on with her, and so like I kind of like pulled her aside and was kind of inquiring, um, and she disclosed some stuff to me, and then when she went back to where she was staying, was kind of like, hey, I want you to be my therapist because I feel more comfortable with you than I ever have with any other therapist. And I'm like,
Cute.
oh,
Oh,
that's, well, it's a conflict of interest. Like
yeah.
I'm good friends with her sister, and she also lives in another state, and I'm only licensed to practice in one state, and only in
Oh,
California, so I can't practice across
Mhm.
state lines and stuff. Yeah, there's just like, I would not have lost my medical license for it,
yeah.
but it is definitely something that like, American Psychiatric Association and if I had told any of my prior supervisors that I was doing this, they would have been like, dude.
Yeah.
Yeah.
Hello. I hope you're enjoying listening to today's episode with Girly Lily and Girly Vero interviewing Dr. Bello. But it's that time of our podcast where we go ahead and take a smoke break. So choose your favorite method of consumption and join us. And we'll jump straight back into the conversation after this. Stay tuned.
Let's talk about the medication aspect of being a psychiatrist. Lily has
Mhm.
a really great question about this because this is a stigma that I grew up thinking as well.
Same with me. My question is, how do you feel about the stigma behind psychiatrists pushing medication?
I think so. This may be controversial, and some of my colleagues might be pissed about this, but I do think that there is a tendency to overprescribe certain medications.
Mm.
But I do think that's largely because there is a tendency to overdiagnose certain diagnoses, especially amongst people of color, and especially amongst people of lower socioeconomic status.
Mhm.
And this can't like I really this is one of the reasons why I left the county system, because I think that there's a lot of people of color get grossly overdiagnosed with bipolar disorder, schizophrenia, schizoaffective disorder, when a lot of them, it's really the diagnosis is PTSD plus or minus substance use. And so they like, you know, yes, if somebody has schizophrenia or bipolar disorder, they like almost by definition have to be on a mood stabilizer or an antipsychotic. The problem is those classes of medications have a lot of side effects, both in the short term and in the long term, including some irreversible side effects that, like, if you get the person off the medication, the side effects don't go away, including like something called tardive dyskinesia, which is like a movement disorder. So like,
Oh, wow.
like a squirming, it's not quite a tremor like Parkinson's, but same kind of family of things. And so it's so important that you actually get the diagnosis correct. I think with other things, well, actually, I'll add one more class, and that's the benzos. I don't ever prescribe Xanax to anybody. And again,
why is that?
Both because it's like one of the most addictive medications on the market, like worse than opioids, I think. And two, I have some personal or some experience with it with people in my personal life, including a friend of a friend who OD'd, and one of my best friends growing up who was at a party and popped a Xanny and got into his, like, blacked out. Nobody stopped him from getting into his car, and he drove himself into a tree, not in a suicide attempt, but because he was like, crossfaded and blacked out. Yeah. And so I just like primary care doctors and a lot of older psychiatrists like hand it out like it's candy, and it sits in people's drug cabinets, and their kids and other family members find it and they mess around with it or they sell it or whatever. So I'm like, I'm pretty conservative with benzos. I'm a little bit more liberal with antidepressants and stimulants. The antidepressants I'm the most liberal with, just because the side effects are like pretty minimal. There's no long-term stuff. Yes, there's a couple like potential lethal ones, but that's really only if people try to overdose on it. The risk of serotonin syndrome, which is like a medical emergency. It's like it's like what happens when people take too much ecstasy. Yeah, it's the same thing. So the ecstasy causes a massive dump of serotonin. So it's the same thing if you take too many SSRIs or antidepressants. But yeah, other than that, they don't really have like really severe side effects. So like worst case scenario, you get really nauseous and throw up, and then you stop taking it and it goes away.
Okay.
Right.
Yeah.
So I'm sorry to hear that about your loved ones and their experience with medication. That's not fun. Have you ever dabbled in any of these kinds of meds? I don't know if this is another no-go.
That's the other one that I won't answer.
Do it!
Yeah. Because again, if with this going public, if patients were to hear this, it could go either way. If I say, yes, I've been on things, then people might be like, oh, well, that's his own experience. And so he's just projecting and thinking that like everyone needs it just because he took them or whatever. Or the opposite, it could be if I haven't taken them, people might be like, oh, well, you're prescribing these things that you wouldn't take yourself. So how are you going to, So to mitigate that, I don't disclose.
Okay. King of avoiding cancel culture.
Yeah.
It's just those two. Everything else I'll answer.
Okay. So then next question, how do you determine that one of your patients needs a medication and which medication? I know it's a trial and error process, but what's your way of going about it?
It's like I was saying before, I mean, the most important thing is getting the diagnosis right. And so I generally, this is like one of those things where like when you're a hammer, everything's a nail kind of thing, but like trauma's always been my biggest interest. So I kind of default to attributing people's presentations. Like if there's trauma, I generally will think, okay, most likely that's the most important factor first and foremost. I mean, I tend to think like, there's like the DSM checklist of, okay, yeah, technically this person has X, Y, and Z symptoms. And so they might meet criteria for X, for whatever thing, but there's a shit ton of overlap in the symptoms between various diagnoses. And so you kind of have to, get a better characterization of like, like someone can't focus that could be ADHD. It's literally a criteria for depression. It's criteria for generalized anxiety disorder. If someone has OCD, they could be in their head, like, obsessing about things. They're hearing voices because they have schizophrenia, that could be, a reason they can't focus. So you really have to like tease it out. And then like, then from there, I mean, more important than I think like whatever I check for insurance purposes or billing purposes, I tend to more think about somebody's life in like a narrative format of like what they, how does what they've been through or what they're currently going through, how could that be contributing to like what their presenting symptoms are. And then like from there, then, again, I'm generally pretty liberal when it comes to the antidepressants, and those are the first line treatment for like PTSD, generalized anxiety disorder, panic attacks, OCD, major, any kind of depression. So you hit a kind of a wide variety of diagnoses with that. But yeah, like you were saying, it is, if somebody's got depression or anxiety, there's a dozen different medications that are FDA approved for it. From there, it's just kind of like a crapshoot. So, between like the three most common antidepressants I use are Zoloft, Prozac, and Lexapro. Between the three of them, there's no difference in what really in their mechanism. It's just because of genetics, different people respond differently. And so I just arbitrarily start with Zoloft. That doesn't work, go on to the next one, usually Lexapro. If that doesn't work, then we go into Prozac. And if that doesn't work, then we kind of expand to some of the other antidepressants.
Interesting.
I mean, I'm generally, these medications generally kick in within a month. So like, if it's not working within a month or two, there's no reason to
keep going.
with it.
Yeah. All right, so let's talk about a session with a psychiatrist, because not a lot of people have the luxury, unfortunately, of being able to visit a psychiatrist and get the help that they need. So, if someone's visiting you for the first time, what do they expect? What kind of questions besides what were we saying, Lily? What's the question that we always get asked?
How do you feel about that?
Or
how are we feeling
today? That's usually when the tears start rolling down after that question.
Oh, my favorite is like when someone's telling a story. If I can see that, because all you have to, like, the most expressive part of the face is this. So even with the mask on, the moment I can tell, that's like, if you really watch someone's eyes, sometimes I'll catch just for like a split second the sadness come up when they're telling a story. And as soon as I see that, I go, hold on, wait. What's coming up for you right now? And the moment I say that, it forces them to stop talking around their feelings and actually turn inward for a second. Because sometimes they don't even realize the sadness is coming up. The moment I say that and they turn inwards, gushing, the tears come down. I'm like, so yeah, it's something one of my mentors taught me, that just always be looking at someone's eyes.
It's so embarrassing.
Yeah, that kind of triggered me a little bit right now.
Okay, but what should a patient who's never been to a psychiatrist expect when coming to see you for the first time?
Sure. So, I mean, I'm always going to ask about like general categories of like, what are the presenting symptoms? Like, is it depression? Is it anxiety? Is it concentration problems? Blah, blah, blah. For me, and this is what I've been teaching my med students that I've been hosting, timeline is the most important thing that we need to get. So like, a lot of patients come in and they'll start telling stories at like all kinds of different places and stuff. And so like, if you really want to help your psychiatrist or any mental health provider, always, when you're going to tell a story, start off with like, when I was this age or this many weeks or months or whatever ago. So that way, you kind of have an idea of like, it's a lot easier for me, focusing on trauma, like, oh, okay, so 3 years ago, this thing happened to you. And then like, a month later, you started having X, Y, and Z symptoms. Maybe these two things are related, so that kind of stuff, and I'll kind of go through, ask questions that are sort of probing for different diagnoses. Again, trying to get the diagnosis right more, first and foremost. After that, I'll ask like a handful of questions about like physical symptoms. any past psychiatric stuff. So like, have you seen a therapist or psychiatrist before? Any suicide attempts, hospitalizations, self-injury, any meds you've been on? I'll ask about past medical history, especially like most important things are like, you ever had any concussions or seizures, that kind of, the things that are like loosely related to mental health. I'll ask about social history stuff. So like, who you living with, tell me a little bit about your family background, how's your relationship with your parents, mommy issues, daddy issues, that kind of stuff, siblings, are you in school, are you working, and then like I'll ask about nicotine, drugs, and alcohol. And then if it's a kid, I'll ask about developmental history. So, or I'll ask more so the parents, like, were they born premature, any complications during the pregnancy or delivery? How are they hitting all their milestones, all that kind of stuff?
Huh. Yeah. Interessante. How much information is too much information for patient to psychiatrist? Okay, so tell me everything.
Tell me everything.
Okay.
Yeah, I think well, okay, so I should clarify that. It depends on if this is a follow-up appointment or a therapy session or an initial intake. So I would say if it's like the first time you're seeing your psychiatrist, know that they have to like cover broad strokes. And so,
what does that mean? Broad strokes.
So like all the stuff I was mentioning a minute ago about like, we have to ask all these categories of things about your social history, about, a million different questions about the presenting symptoms, your medical history, all that stuff. And most psychiatrists are doing their initial appointments in anywhere from like 30 to 60 minutes, 60 minutes on the long side. Usually it's like 30 to 45, but I do 90 minutes because I'm weird.
No, it's good. It's good. I think that you need that for the first initial one to build that trust.
Yeah. Yeah, I do too. But most people out there, if you go see a psychiatrist, it's not going to be 90 minutes.
Yeah.
But yeah, because of that, they have to cover a lot of different things. I would say in the first appointment, definitely get out the things that are the most important to you, but then, maybe try to just directly answer the psychiatrist or the therapist questions. You don't have to give a full 10-minute story on to answer every one of their questions.
Yeah.
But later on, once you're established and they kind of know your general background and you're, especially if it's a therapist, not a psychiatrist, then yeah, you should talk about everything. I mean, really uncomfortable stuff, like people's some very graphic sexual behaviors. I ask patients about their masturbation habits sometimes, if it's relevant. I have some patients, again, with sexual trauma or whatever, that are trying to, they want to be more comfortable with their intimate partners, but they keep getting trauma memories coming up. And so they have to kind of to move to work on that. I often encourage them to, I'll ask them about okay, well, are you more comfortable when you masturbate? If so, what usually is going through your mind? And then I encourage them to work on their fantasies or whatever by themselves. And if trauma memories start coming up, even with, self-stimulation, then pause. The moment those things start to come up, wait till the memories go, those intrusive thoughts go away, and then resume what you're doing, so that your brain, it's it's classical conditioning, or like Pavlov's dog kind of stuff. You only want sex to be associated with pleasure and happiness, not trauma. So you have to, repeatedly break that association, and then, work on that with your partner. But yet, you kind of have to be open with them too, right? So yeah. Anyway, point being that there is no, anything that, there is if you're embarrassed or ashamed about it, trust me, your therapist or your psychiatrist has heard whatever you're ashamed to say. They've heard it before, and they've probably heard worse.
Yeah. Well, we are actually talking about this before you came in, about how in our previous mental health journeys, we wouldn't be super honest with our providers, and that only would backfire on us. But yeah, I think that leads perfectly to the next question, Lily, if you want to Ask that one. I'm interested.
Yeah. My question was, can you ever tell when a patient is lying to you? Like when they're telling their stories, do you ever feel like there's a hunch that it might not be true?
Sometimes. Yeah.
Yeah.
Yeah, I mean, it varies from patient to patient. A lot of times if I ask, like, patients will give me kind of vague stories about stuff, and when I probe and ask more detailed questions to kind of clarify, or like if something's like not something about the story is like not quite adding up, I'll ask, wait, so this this person said this and then this happened, what's how did we get from A to B or whatever, and if they're like struggling to answer that question, it's possible they just don't remember, especially if it was a long time ago. But a lot of times I start to wonder, like, okay, maybe this isn't entirely the truth. And same thing with my child patients. A lot of times the kid will tell me one version and the parent will tell me a very, very different version. And so usually the truth is somewhere in between. But except when it comes to like, like prescribing controlled medications, apart from that, the exact truth of what happened is a little less important than the patient's perspective on what happened, because that tells me a lot. Like the way that like sometimes it's not the details of the story that matters, it's what they choose to include and what they choose to like gloss over. So that's another thing, is sometimes when they like don't include, they're kind of vague about certain things, a lot of times they're either intentionally or unconsciously avoiding where the actual important stuff is.
Yeah.
And so that's why I'll go back, that kind of tells me something. And so I'll go back and go, pick at it a little bit.
Try to connect the dots.
Yeah. The math ain't mathing.
Yeah.
No, I mean, I all I can speak on is my experience. And when I was not being completely honest, it wasn't like because I wanted to lie. It was just I wasn't fully comfortable like sharing that yet. So they'd be like, "So how have you been?" "Oh, I'm good." Like had a breakdown in the car. Yeah. That kind of thing. So.
Well, and I've had patients like because I used to, before my current job, I used to work at a clinic in Compton, and it was a routine thing so the therapist would always see the patients first and then they would send them to me afterwards. And so like, before I would end up seeing them, every week we would have like a group meeting or like a team meeting or whatever. And so they would kind of present the patient to me and say like, okay, yeah, this person you're going to see is this age, this is their background, blah, blah, blah. And a lot of times I would listen to the story and be like, so what's the patient's trauma? And they're like, oh no, they denied trauma. And I'm like, I don't know about that. Like everything that you're describing to me sounds like something that like somebody who's been through trauma would do. And then sure enough, when I meet the patients and I ask them, the trauma comes out. And I'm like, and again, this is not to brag, or I don't think there's anything like special about me, but I've had some good teachers, that have taught me how to like kind of get around the defenses and make people more comfortable. And so like, I would say more so than some of my colleagues, I tend to get honest stuff, as far as like the stuff that you were talking about that you probably were uncomfortable talking about with some of your prior providers. I'm usually pretty good at getting that stuff out of people. But I also don't like, sometimes, I'll just say to them like, hey, some of the stuff you're telling me is kind of concerning, and I'm wondering if there's more going on than you're ready to share. And they'll just be like, no. And then like months later,
it'll come out.
Yeah, it'll come out, and I'll be like, yeah, I kind of figured.
Well, since you brought it up, Peter,
if I go to a doctor and I'm like, hey, my arm hurts, whatever, but I can't go to a psychiatrist to be like, my brain is not working. Like, how do I explain that to someone? It's tricky for sure.
Yeah. And I think a lot of that's just because there's so much stigma against mental health that, people treat mental illness as if it's different than, any other illness.
This hasn't happened to me, but like if it ever did, if I'm at Ralph's one day and I see either, my personal therapist or you, do we wave hi to each other, or we just continue shopping for our groceries? It's just like, what do we do in that situation?
That's up to you. So
Okay.
what we will do is, I mean, we may just either pretend that we don't see you, or we may just kind of look past you and just like just give you like a hi
A
kind
little
of thing.
nod.
Yeah. So this is something they actually explicitly talk about in training, because especially in small towns, it happens a lot. Um, and so for to avoid the inevitable conversation of like, oh, who is this? How do you know this person? So like if I'm with like a group of friends or something, and you see me at a restaurant or whatever, and you come up and introduce yourself, obviously the people that I'm sitting with are going to ask, oh, who's that? You know,
Just
you know,
chick.
and for confidentiality reasons, I can't answer that question, right?
Yeah.
So I think they generally will tell us, like, you know, if you were to come up to me and approach and just be like, hey, Dr. Bello, and like introduce yourself as, hey, I'm one of his patients, like,
What can you do?
Yeah, I'm just gonna be like, hey. But yeah, no, if you were to just walk by and just like wave at me and say, hey, how's it going, or whatever, I mean, hey, first off, if you call me Dr. Bello, probably they're gonna assume that you're either a coworker or a patient. But I think if they asked, you know, we would say something along the lines of like, oh, it's somebody that I work with or worked with, something like that. And that doesn't, you know, it's not necessarily a lie, it just doesn't answer the question.
It's not the truth.
Well, no, because technically I am working with you as in a patient-doctor relationship, but it doesn't answer that question for them, you know, of is this a patient or is it a coworker kind of thing.
It's just like an uncomfortable situation overall.
If I ever saw someone in public,
I'm just gonna tip my hat and just keep it going.
Don't expect me to say hello.
Yeah. I think I've only had it happen maybe once or definitely once, maybe twice. It happened a couple months ago because there's a Nine Bagels downstairs from my office, and so there was a guy who lives in the area, and I was getting I was picking up my bagel or whatever, and he's like, oh, hey, Dr. Bello, it's so weird seeing you out in the real, you know, out in your office. And I was like, and I mean, just general kind of boundaries, if you're wondering, there's stuff like it is 100% never acceptable to date or have any kind of intimate relationship with obviously like a current patient, but even if the person was your patient 20 years ago, for the rest of your life you can never have a relationship with them. You will lose your license for that. And same goes obviously for child psychiatrists or child therapists. You can never have a relationship with their parents. That is if anybody ever found out that that's how you met, you would immediately lose your license and never be able to practice again.
Rightfully so, in my opinion. I think in this field, it's know too much.
Yeah, and it's in general, it's generally pretty discouraged to have any sort of like dual relationships with your patients, which is again that like friend sister, same kind of thing, because we run in the same social circle and all that kind of stuff. So for her to be both a patient and you know, friend sister, you know, it puts you in a really uncomfortable position. Same thing like in getting into like business endeavors with them, that kind of stuff. It's just generally frowned upon whenever possible. Again, if I was a psychiatrist in like, you know, some small town in Nebraska or something like that there's only a couple thousand people, like, and I'm the only psychiatrist in that town, like, yeah, probably, you know, I'm going to see the kids of my mechanic or you know, whatever, like it's kind of inevitable. But you know, obviously in LA metropolitan area, there's no reason for me to engage in that.
If anyone was interested in, after listening to this, they're like, you know what, kind of sounds cool, maybe I want to seek care from this guy, what should they do?
So if you look up so the name of the clinic, is Memorial Counseling Associates. The address is 4525 Atherton in Long Beach. Phone number is 562-961-0155. Alternatively, if you're on the fence and you want to, see a little bit more about like my general practice style and what to expect with me and stuff, I have my own website. It's just brianbellomd.com, and that's Brian with an I, Bello, no W at the end, md.com. Yeah.
Okay.
And there's links to like the clinic's website and stuff on there too.
Okay, and can they set an appointment there, or they'll have to reach out to the clinic?
No, you have to call, and you'll talk to my intake people, Carissa, and she'll kind of just make sure that your insurance is something that I'm covered under. Because if not, it's you have to pay out of pocket. And those prices are obviously a little bit more expensive.
Yeah.
Yeah, but I mean, I take a lot of the Medi-Cal carve-out plans and stuff. None of us take straight Medi-Cal at the clinic, but any of the carve-out plans. So,
okay.
I have a question.
Yeah.
How do you feel about the app, or I think it's an app, Talkspace or BetterHelp? Yeah. How do you feel about those apps for someone who's not? I don't know how their insurance thing works, but I know that's becoming a lot more popular, especially right now with the pandemic going on.
I think if you're desperate and you have nothing else, go for it.
Okay.
Or if you if everybody in your area is booked, I think it's better than nothing. I think, I don't know. So the problem is there hasn't been, as far as I'm aware, there hasn't been any really solid research on it. Or maybe there is and I'm just ignorant to it. But I would have to look to see, are they tracking what their what their outcomes and stuff are, and I'm not familiar with it to be able to go yes. I think I've had a couple patients that have told me they were doing it for a little bit, and they said that it helped a little bit, especially when they were in their lowest moments. But that they've hit kind of a plateau where yeah.
Okay.
Yeah.
Why? You're
I feel like it's fairly new.
Now?
No, I feel like it's coming out a lot more often now, and for me, it's new to me. So I'm just wondering how other therapists or psychiatrists feel about that.
Yeah.
Yeah, I think I'm trying to, because I get emails every couple times a week to once a month from the medical journal, the Journal of the American Academy of Child and Adolescent Psychiatry, and Journal of American Psychiatric Association,
American Idol.
Yeah, Journal of American Idols. Yeah, but the American Psychiatric Association's journal, that kind of stuff. And I don't recall reading any specific articles on whether or not they've taken a stance on these things. They probably have, and I've just been too busy and blown it off.
Yeah.
But yeah, it's something that I probably, to be honest, just need to educate myself on to see what data is out there on it.
Yeah. Okay. But I mean, resource is a resource. So
yeah.
I think I think most things are worth at least trying. I think they're cheap enough to where worst case scenario, you're out $20, because I think it's for one of them, I think it's $20 a month. I think the other one's 65 or something.
Huh?
Yeah.
Yeah.
Oh, it's like a subscription?
Yeah, and I think you get unlimited access to a therapist. I don't know if you're assigned to a specific one, that's the only person you end up talking to, or if it's that's kind of if you reach out, it'll default to that person. If that person's busy, they'll match you with someone else. I'm not quite sure how their system works.
Yeah. Huh. Okay. Well, I have to check it out. Okay. Well, I think we're good to wrap it up. Okay. Thank you very much for answering all our questions, because we had a ton of them, and we're excited to put a psychiatrist in the hot seat, because we're always in a hot seat. by psychiatrists. So any plugs, anything that you have going on that you want the people to know about? I don't know if you want people to find you on social media and all that, but
so I actually have 3 Instagram pages at this point because
okay.
I had for the longest I had my personal one that I have on private, and I explicitly have on there like, unless you are an IRL friend, I won't add you. But I've had multiple patients try to either like DM me on there or try to like follow me, and I've had to like politely like, hey, you know, for privacy reasons, like I, you know, whatever. But then I also have my like music one of, you know, because in my free time I play bass in a band. You know, this will be my plug. I play bass in a band called Move Like Creatures, which also has its own Instagram page. But yeah, I have my own, like, you know, Brian Bello bass player, whatever, Instagram page. But because I kept getting DMs, I made a Dr. Brian Bello one that people can check out. I don't really post on there. It's more of just like I was mostly just hoping to beat the algorithm so that people stop clicking on
your personal one.
Yeah.
His Finsta.
Yeah. I have a patient that decided to follow me on Twitter, but I also don't really tweet.
Okay. But this band, where can people find you guys? You're on Spotify, Apple Music. What's the sitch?
So we're actually in the studio. We've been recording an EP. Pretty much all the tracking's done. I think we're meeting up tomorrow to decide what one of the songs needs some changes or whatever. But we're hoping to release our first single probably in like May, I think. Yeah, and then there's been debate back and forth about whether we release the whole EP together as one package or singles. They all want to do singles, where I'm still all about the art of an album. but I think
creative differences.
Yeah, but it's fine. I think we're gonna end up just doing singles. But yeah, the first one. Tangent. Sorry.
Go nuts.
Our singer has the ADHD herself, and she's like pretty open about. So like most of the songs are about mental health related stuff, and she wrote most of these before meeting me, so it was just like a funny coincidence. But the first single is most likely, I think we're going to go with a song called Mind Reader, parts of which are about her former psychiatrist. And there's like a line in the song about you know, something, I forget the exact line, but it's like, you know, you said to me that there's only so many times that you can put yourself back together, and she was like, this bitch. So now it's like immortalized in a song.
Yeah, what the heck? That's funny though. Look at the psychiatrist singing about psychiatry.
Yeah.
Okay, well, again, thank you so much. We already took up a gazillion hours of your time.
No worries. Yeah, no, thank you so much for having me. I really enjoyed doing this. It's good to be again back on the air, because it's been coming up on 1 year since the last time we did an episode on 22 West.
Okay, well, I mean, you're always welcome. You could be the residential psychiatrist of the I Don't Know podcast.
That's literally what happened with the last one. I started off as a guest, and then they were like, to validate what they were doing, because they were specifically a mental health radio show, and none of them worked in the profession. So they're like,
bring in the guy.
Yeah. Like, yeah.
A reoccurring character.
Yeah.
In the podcast.
Yeah. So, I mean, if you guys ever need me again to talk about specific topics within mental health, I'm happy to do that.
All right. Thank you so much. I hope you have a great rest of your night, and I will speak to you soon.
Sounds good. Have a good evening, guys. Have a good weekend.
Bye.
Stay safe out there.
You've now reached the end of the episode. You've made it, you guys. Thank you so much for listening to today's episode. I hope you guys enjoyed it as much as we enjoy recording for you guys. And don't forget to follow the Girlies on our social platforms. We have Insta, we have TikTok, we have YouTube. You could follow us at the Girlies Pod, and you could stream our show on YouTube, Apple Music, and Spotify. Thank you so much again for listening to this week's episode, and we'll see you next week. Bye.